Hi, I'm Ken Currington. I'm one of the surgical educators here at Camels, and I'm going to demonstrate for you now the use of the laryngeal mask airway. This is usually used in the acute setting where a patient cannot be easily intubated in the field or attempts were made and were unsuccessful. It can also be used electively in short operations. Anesthesiologists often use the LMA for the administration of their anesthetic gases. They work quite well. They will not ventilate as well as an endotracheal tube, but the idea in this case is to get some type of airway in to keep your patient alive until a definitive airway can be established. So if you look at the tube, you can see that it comes in different sizes. In this case, this is a number 5.
There we go, okay.
It's single use, of course. It even gives the dimensions of the tube. The tube has a balloon, which in this case I've partially insufflated, and we'll explain that in more detail in a second. You can see on the inside that it simply opens into the center of the balloon on the underside. There is an insufflation port with an insufflation balloon here that allows us to detect the amount of pressure by feel that we have put into our actual LMA balloon. The tip of this is quite stiff, and we want that because it facilitates the advance of the tube. So the idea of this tube is to put it in such a way that it fits into the oropharyngeal laryngopharyngeal junction, and you can see it's directed anteriorly so that air in this case goes through the tube and is directed anteriorly down the trachea and not down the esophagus. Laryngeal mask airway. So I have the balloon slightly inflated. This facilitates passage. If it's completely inflated, you may push it actually down too far. Although that's difficult to do, I have seen it done. So I have very slight insufflation of the balloon. If you're unsure how much air you're going to eventually need in the balloon, most of the insufflation balloon indicators will have a number that tells you, in this case, greater than 55 milliliters will be necessary to fully insufflate this balloon. And proper insufflation of the balloon upon completion is important to provide the seal that we need. So I have about 10 to 15 cc's of air in the balloon so far, and I have my syringe ready to put in another 30 cc's or so. I have it directly attached to the insufflation port, and notice it engages the red valve so that when I push, air will go through the valve into the balloon. The patient is unconscious and supine, or the patient's could be on their side. It's very difficult to put an LMA in on the side, but I have seen it done. Most of the time the patient will be supine. If there's any concern about the patient's C-spine, you do not have to extend the neck. We open the mouth using the snap finger technique, which I've demonstrated previously. The thumb goes on the bottom incisors. The middle finger goes on the top incisors, and you can see that the mouth easily opens. In this case, I will have lubricated this tube if I have jelly on the outside of the balloon. A smaller rim of lubrication jelly will allow this to pass more easily. Very cautious to make sure that no lubrication jelly has worked its way into the lumen of the tube. So the back side of the balloon, so to speak. Open, and notice no laryngoscope, no visualization of the cords. I simply follow the hard palate back and advance the tube until I meet resistance. And I don't force it. I'm using this because it gives me a good feel for the depth of the balloon and the resistance that I have. Now I push until it's presumably now in the hypopharynx. I cautiously blow the balloon up. I can feel that this has adequate pressure that's being maintained by this small indicator balloon. Notice my thumb does not come off the plunger until I detach the syringe. So I control the syringe phalanges with my index finger and my middle finger, and I control the plunger with my thumb. Look what happens if I take my thumb off to detach the syringe. Notice the plunger automatically withdrawing. That means the pressure in the balloon is pushing the plunger back. Now I have inadequate insufflation of the balloon and an inadequate seal for ventilation. So I maintain the plunger pressed in with my thumb, detach. Now there's complete insufflation of the balloon. It's in the proper location. I should be able to attach a bag valve mask, and you can see that I can ventilate. Now the mannequin is not going to seal like a human being, but you can see that even in this case, I would be able to get enough ventilation to keep this patient alive. The idea being now, let's transport them to a definitive facility and get a definitive airway. So, laryngeal mask intubation. Laryngeal mask airway intubation.